Thanks everybody for coming to the second Dublin Salon on the all-important theme of assisted dying. I know it's a sweltering evening outside, and I know that AC/DC are playing, so you know, just rock on. So yeah, I appreciate you coming very much. This is our second event, as I say. We had a big data event back in April, and in some ways this is a more fraught and controversial topic. And I suppose that's why we decided, the Salon's co-founder Brett Becker and I decided to make it a two-header with opposing sides of the same debate. It's never out of the news for very long, as we know, the case with Gail O'Rourke. Shortly after we had decided to have this event, the Gail O'Rourke case hit the headlines, and periodically there are these flashpoint cases that make it a very important debate to have. I'll first of all say a little word about the format. Each of our two speakers will speak for 10 to 12 minutes, one for, one against. Then between ourselves here at the top table we'll have a discussion based on points arising from what each speaker has said. And then, and this is very important, it goes out to you to ask questions, make comments, criticisms, dirty limericks, whatever you want. It's all welcome. And depending on how long that takes, we kind of have to be out of here by 8:15, 8:30, so we'll see how we go. I'm going to introduce our speakers first. And then I'm going to take a quick poll on the question, should assisted dying be legalised? Right, show of hands. I'll do it after we introduce the speakers. And it will be interesting to see, we'll do it again when the event is over, and see has there been any change. This was Jackie's idea.
That's my disadvantage.
Okay, so speaking for legalisation, I'd like to welcome Dr. Jackie Davis. Jackie is the chair of healthcare professionals for assisted dying, is that right? In the UK. She's a consultant radiologist specialising in paediatric and breast imaging at Whittington Hospital, a founding member of KeyBar NHS Public, and co-chair of the NHS Consultants Association. And she sat on the British Medical Association Council since 2006. The cause of the NHS is very, very dear to her heart. She lectures around the world and is a regular contributor to The Guardian, the British Medical Journal, and she's co-authored the books NHS SOS and the recently published NHS for Sale, Myths, Lies and Deceptions. The campaign for assisted dying is very dear to Jackie's heart because her brother died of cancer some years ago. So that's Jackie Davis. Kevin Newell, making the case against assisted dying, is a historian, author. He's published in The Tablet, The Spectator, the Canadian National Post, Spiked and New York Times. Based at the University of Sunderland, his chief area of interest is American history, social movements of the 1970s, and this of course brings in right to die movements, as well as gun control movements. He's the author of Richard Nixon and the Rise of Affirmative Action, the pursuit of racial equality in an era of limits, and most pertinent to our discussion this evening, he's the author of this, 3 copies for sale, snap them up. Assisted Suicide, a liberal humanist case against legalisation, and an extremely provocative read it is too. The aforementioned poll. A show of hands in support of legalisation of assisted dying? I think that's...
Should we write down
for the benefit of the podcast, that looks to be about half the room. Is it? No, it's actually slightly more than half. That's more than half.
13.
14.
13.
13, okay. Thanks, Brett. And against? It's 5. Oh yeah, is anybody undecided?
1.
2, 3.
3?
Sorry, you go ahead and see. Did you?
I'm here.
I counted it.
Oh, okay, good. Okay,
3 undecided.
okay. So 13 for, 3 again, 5 against, 3 undecided. Over to you, Jackie.
Could I start with some water?
Oh, certainly, yeah, sorry, I'm going to piece.
Okay, thank you. You've heard a bit about me. My background is really in campaigning for the NHS, which I've been doing for the last 10 years, English NHS. And this is a relatively new area for me, so I beg your indulgence a bit, not too much, but just a bit, because I haven't done a lot of public speaking about assisted dying. I'm speaking as chair of the Health Professionals for Assisted Dying, which is a group of health professionals in the UK who believe that assisted dying is, its time has come. And we fight for assisted dying as per Lord Falconer's bill, which made some progress through the House of Lords recently. Does everybody know what the basic stipulation is in Lord Falconer's bill? No, yes, no. Okay. What Lord Falconer is asking for is what is based on what has been in place in Oregon for the last 18 years. And essentially it is assisted dying for people who are terminally ill, who are thought to have 6 months or less left to live, who are of sound mind, and psychiatrists can be brought in to judge that, who have a settled intention. In other words, they don't want to do it one day, not the next day. And that is what is on offer here, and that is what's going to be discussed in the House of Commons in September. That's why it's suddenly become such a high-profile issue in England, because Lord Falconer's bill made good progress through the House of Lords for second reading, and only fell because we ran out of time. So now it is the person who won the poll for the private members' bill in the UK has taken it up as his cause and is being debated in September. So it has suddenly become a real live issue in the UK, with the possibility of having a law, although personally I don't think it will happen for reasons that we can go into later. The arguments for assisted dying, I think, are quite easily put, although people may not agree with them. The first is that suffering is bad, and unbearable suffering is very bad, and that preventing assisted dying is cruel. The second is the sovereign principle of autonomy, that we accept patient choice everywhere else in medicine. When I qualified many years ago, medical profession was very paternalistic, and we often didn't listen to what patients wanted. We told them things, we withheld information from them, and we were paternalistic. And during the course of my lifetime as a doctor, we have really, quite rightly, moved to patient choice at the centre of everything. And you can't make patients have operations they don't want, or take medicines they don't want, or do things they don't want, even if you think that their choices are wrong. It's about patient choice. So our belief is that this is another patient choice, a big one, a huge one, but it should be dealt with in the same way. And the third argument for having a proper law about this is, as things stand at the moment in the UK, the law is a mess. It's a clinical, it's a legal, and it's an ethical mess. There are really no safeguards in place. All sorts of things are going on behind closed doors that we don't know about, and this law would be a massive safeguard. The arguments against are interesting, of course. Perhaps I should be contentious, because what's the point in bringing me all the way from London if I can't be a bit contentious? But I think many of the arguments against assisted dying actually have a deeply ethical and religious basis. And there's absolutely nothing the matter with that, that people should believe on the basis of ethics and religion that it's the wrong thing to do. But we, certainly in the UK now, I don't presume to speak for Ireland, we have a secular society, and so those arguments don't really wash anymore. If you say life is sacred because God gave it to us and only God can take it away, a lot of people are going to say, oh, I'm sorry, that doesn't wash with me because I don't believe any of those things. So to a certain degree what's happened is that the people who have those very strongly held beliefs, and I would never diss them in any way because that's such a personal thing, overlay them with their concerns about assisted dying. And I just want to run a little bit through the concerns and the arguments against assisted dying. The first is there's no need for this law because suffering can be avoided. Well, I know as a doctor of 35 or 40 years, that's simply not the case. I've seen many people die deaths that I would not want to die myself, even with the best palliative care available, and I've seen them within my own family. So I would dismiss that, and we can, of course, come back if you want to and enlarge in all these areas. Another concern is that, if you allow people to die at the end, then palliative care will get worse because there won't be any need for palliative care. We know from Oregon that isn't the case. That there are no safeguards in Faulkner's law. Well, in fact, what's happening at the moment is a giant fudge. And what we've got in the UK is the equivalent of backstreet abortion before the abortion laws were passed, because all sorts of things are going on behind closed doors that we don't know about. And doctors admit to seeing off patients. Other doctors daren't see off patients. I've had one member of my own family, a doctor, that was suspended for 2 years for giving an appropriate dose of morphine to a patient while he was investigated. And many doctors are afraid of giving the right dose. So there's a lot of sort of things that we don't know about going on behind closed doors without these safeguards in place. Slippery slope argument is used a lot, that, oh, well, if we start with this, we'll all be down the slippery slope. And I would again come back to Oregon. The law you get is the law you pass. The law that's on offer in the UK, and this is specifically what I'm going to talk about today, is based on the Oregon experience, and there has been no slippery slope in Oregon. The thing about Oregon that's so wonderful is that they went out on a limb and did this thing before anybody else had, and it has been under the microscope like nobody's business you can imagine. For the last 18 years, everybody has been watching and looking at for all the things that they were worried about: coercion, slippery slopes, increased suicide, poor palliative care, all those things they've been watching for, and they haven't happened. People will say, well, how can you tell if somebody's going to die in 6 months? You know, that's a very kind of loose thing. Well, I would put two things up against that. One is that the doctor's prognostications are notoriously optimistic. In other words, we think people are going to live longer than they do. And the second thing is, these people who sign up for assisted dying, they are not people who want to die. They are people who want to control their deaths, and I think that's a really important thing to think about. And I know there's going to be a challenge to assisted dying, is it assisted suicide? These people are not like suicides. They don't want to die. What they want to do is know that they can control their death when the time comes, if the time comes when it is unbearable for them. And so if you live 9 months instead of 6 months, well, that's lucky you, because you, while you're living that 9 months, knowing that you have a terminal illness that's going to kill you, you have the emotional assurance that at the end you will be in control of what happens. So I think the prognostication thing is a red herring. Mistakes, will there be mistakes made? Well, you know, we know big mistakes are being made at the moment. There is a 14-day pause after you ask for it, when you have to consider it. 2 doctors have to assess you, psychiatrists can be brought in, and what's been added in the UK now after the House of Lords is judicial review. So there are many, many safeguards built into this. The Oregon experience has been so important that, of course, people keep misrepresenting it, and we can come back to that as well if it's necessary. I just want to give you some figures about the UK. 82% of the population want legislation on assisted dying. 71% of those who describe themselves as having religious belief want assisted dying. I forget the figure for disabled care. It's very high, 90-something. What's interesting is the leaders of all these people are against it. Indeed, the same for my own profession. The recent poll shows that most doctors are either for it or neutral and want their professional bodies to be neutral on it. But our leaders aren't listening to us in the same way as the medical profession is not listening to the patients. What I would say is we've got a balance here, if you like. And on the one hand, we know what is happening. We know that one person a fortnight is travelling to Switzerland, dying prematurely because they have to travel when they're still able to travel. We know that probably 300 people a year are committing suicide while they're terminally ill because they're frightened of their death and their inability to control it. So we have those people in one side of the balance, if you like, and on the other side we have fears that can't be justified, and we have no extra people who have died in Oregon. We've just had less suffering there. So I offer you that balance, and I offer you, I have no idea where I am time-wise, but I offer you two final thoughts. One is, I wrote a piece in The Guardian about a year ago because my brother committed suicide while he was terminally ill. It was a terrible botched suicide on his own, and the circumstances were miserable. And people came back and said, oh well, hard cases make bad law, to which my reply is, hard cases make hard cases. He was a real person who died a terrible death. Somebody else in my family, who I don't have permission to talk about, also died a very bad cancer death. If I have seen two deaths in my immediate family like that, go figure, multiply that across the country. I don't think there's anything particularly unusual about my family. The other interesting thing that I would tell you is that the California Medical Association have been unable to discover how many doctors they are, but they must run to many thousands, have just changed their position on assisted dying from opposition to neutrality, which is all we ask of medical bodies, because we believe that this isn't a question for society. Doctors can have opinions about the sort of the details, but it's for society to decide. California doctors have just changed their position to neutrality because, I'm told, they feel that they are beginning to be viewed as cruel by patients for maintaining this opposition to assisted dying. And I think, as a profession, speaking as a doctor, we will start to be viewed as being cruel. My voice has just given up. She's the perfect place to stop. That's it. Thank you very much.
Thanks, Jackie. Kevin, I'll come straight to you.
Yep. First of all, I just want to say who I am. Just to say that I'm not a religious person. I'm a liberal atheist, fairly liberal. I favor abortion rights for women, for instance. I am reasonably libertarian, except you'll be happy to know, Jackie, when it comes to universal health care, I really think that's an important principle, so I'm sure we would agree there. I also want to say that my position is not absolute. I don't want to condemn people to live no matter what, and I've personally witnessed situations whereby a quicker death process would have been desirable. And I think the most important thing to do is divide between these individual situations that come up and need to be dealt with, I think, and a changing of the law. And I think there are huge implications to legalizing assisted suicide that I think I would like all of you to think about, really. I can only throw a spanner into the works, because I think most people do support assisted suicide, as I will call it. I do insist on assisted suicide simply because I think it's unrealistic to say that somebody sitting in a room who ingests drugs with the purpose of dying is anything other than a suicide, and that a doctor deliberately giving drugs to a patient with the intention of dying is anything other than euthanasia. I think this is a way that's used to sort of morally back away from the issue and to say, oh, well, this isn't suicide when it's this group of people. And I'll talk about that later. So I suppose my opposition is moral in the same sense. That was one of the few things I agreed with, if anybody saw The Economist magazine this week. One of the few points that I agreed with The Economist was that it is a moral issue that I think we have to grapple with. I simply don't think it's right for the state to needlessly destroy a life. I think even for the very best possible reasons. So I oppose legalizing assisted suicide for the same reasons that I oppose capital punishment. Killing is not always wrong in fact, but it is wrong in principle. Why is this principle so important? We kill in war, in self-defense, but we do so in these situations because it's imperative to do so. It's necessary to do so. There are other reasons for us to do that. It is not simply destroying a life for the sake of destroying a life. We have already the double effect. If any of you have heard of that, that's whereby there's a defense for doctors who administer drugs with the intention of killing pain, and it happens to kill the patient as well. I'm certainly not an expert in that. There's certainly a debate about whether that actually really takes place with, for instance, opioids. I'm sure you could enlighten us, Jackie, on that. But I feel to execute somebody is a pointless destruction. It doesn't really protect anybody with capital punishment. Thinking of capital punishment, there's no great point to destroying that life except for sort of vengeance or some other sort of factor like that. And I think it demeans a civilization to do that. I don't think it's right for us to take a life. It doesn't. If we accept the general consensus that capital punishment saves no lives, it's not a deterrent. What we're doing is really killing people because we simply feel they are too wretched to live. And I think that's true in both cases. What's the difference? Between capital punishment and assisted suicide. The drugs, which are often called cruel and unusual punishment in the United States, are the same or very similar. Capital punishment is much less inclined to make mistakes in some ways, particularly in the United States, where people spend an average of 14.6 years on death row. And what many feel is a wrongful execution creates demonstrations and protests. Not so with those who are mistakenly or wrongfully executed as part of, for instance, Netherlands euthanasia and assisted suicide programs. So a review board that deals with euthanasia in the Netherlands merely reprimanded the doctor who killed Gabby Altruis, I can't pronounce that name, it's Dutch, a 47-year-old mother of two young teenagers because she was killed because she had tinnitus or tinnitus. There are many other examples of situations like that, and I feel we should take these lives very, very seriously. I don't think it's right to say, oh, well, there'll be a few mistakes. We don't think that in relation with capital punishment, and I don't think we should do that in relation to assisted suicide or euthanasia. So some might say that this is needed to alleviate the suffering that many feel. Others say that it's the choice of the person concerned, that it's my body and therefore my choice. The autonomy argument that Jackie pointed to, I think, is very important. And it's, the autonomy argument is worth taking up. I think we come then to the fact of suicide, because suicide really is at the heart of the whole discussion, particularly in relation to the legislation that's being proposed in the UK and also the legislation that's proposed in Ireland, which are both based on the organ model, which, as Jackie explained, it's based on the fact that the patient, so to speak, administers the drug themselves, and that the doctor merely prescribes that. So the issue of autonomy is very, very important, but suicide comes out of this, and so are the implications of this argument for autonomy. We must support, on the basis of autonomy, any request for suicide for whatever reason, so long as the person has a settled wish. And this is just exactly what's happening in Belgium. And I would say look at Belgium and not to Oregon. Oregon has 2% of the population of the United States and is a showcase for assisted suicide or assisted dying, as they call it. I think Belgium and the Netherlands are much more what happens when you have a liberalized attitude towards providing death as a medical treatment. I think that's where we can point it out. So in the news this week, where there was a 24-year-old with suicidal ideation has just been approved for euthanasia in Belgium, and that's the sort of future that I think we can expect. And some people actually will say, well, fair play to them, if that's my concession to Irish. Fair play. I won't try anymore because when I do this in England, I sound like Dick Van Dyke, so I'm just not going to go down that road. If that's what they want, why shouldn't they have that? Why shouldn't anybody? And one of the things that you have to think through is, if we're going to provide this on the basis of autonomy, where do you draw the line? That's a very, very important question. Why is it 6 months to live? Somebody with 7 months to live suffer. Somebody with 5 months to live, that's fine, we'll allow you to have this. And there's no moral basis for drawing that line. And but let's just think about suicide. perhaps some of you will think, well, anybody should be allowed to commit suicide. The 24-year-old lovelorn person has an equal autonomous rights to actually do with their body whatever they want. We should provide assisted suicide for them. Some people may actually think that. I know many people who have debated actually do. I doubt Jackie does, but she can tell us later. And why is suicide wrong? It comes to that great moral question. And I think it's for the same reason that killing somebody is wrong. It's the equal value of human life. We consider the act of killing someone else wrong, no matter who the person is or what their circumstance. We don't say, ah, well, she was 78 and fairly pessimistic and miserable, so that's much better. We should allow somebody to kill that person or give a different sentence, for instance, for killing somebody like that, than, say, a 22-year-old with many things to live for. It's the act of killing that is actually wrong. And we don't make a distinction between the 22-year-old killing a 22-year-old and killing an 88-year-old. We believe that's equally wrong. Most people do. Why would we consider that different for suicide? I don't think we should. This principle that the existence of other people matters to me and that we consider other equal members of the human community is a very important one, and I think it's one that's threatened by a change in the law. So we have run into this difficulty with a case for assisted suicide, is that either you say to the 24-year-old lovelorn person, you're allowed to do that and we'll assist you to do that, or you give them some bizarre reason why they shouldn't be allowed to have that autonomy. Either you base it on autonomy, and let's go to the logical end point of that. If we go down the autonomy route, we really need to support cannibals and their willing victims, because why are their desires any different or any less supportive if we're going down the autonomy route? I don't think that dignity in dying actually goes down that route. What they do is they say that we will divide society, and this is the only other possibility, we will divide society into two groups. Those who we make strenuous efforts to prevent their suicide, and those who are so-called free to go. And therefore you create two different groups in society, and where should that line be drawn? I think that's the kind of question that I'd like to put to you and to make you think. The current legislation that's proposed is based on the Death with Dignity Act in Ireland, and it's well worth reading the Death with Dignity reports. They're very, very informative. One of the things they say is that pain is not even in the top 5 reasons why people take their lives in Oregon. It's usually fear of loss of autonomy, fear of loss of enjoyment of life's activities, and fear of being a burden even comes ahead of pain. So people are not taking their lives in Oregon because of pain, and I think that's important to point out. They're taking their lives for the same sort of existential reasons that affect all of us, that we all might suffer these kind of fears. Or they're taking their lives because they fear living like disabled people, which is why many disabled groups are so opposed to legalization, is because they know that their lives are being demeaned. They're being put in this category of people who are free to go simply by many of in The Economist. If you listen to The Economist proposition, that's very much the case. It may not be in the legislative attempt, but I think it's important. I'll just end on this one point. I think, as Professor Theo Boer points out, and he's a very interesting gentleman from the Netherlands, where he was he was very much in favor of euthanasia when he put it out. As he points out, it was only 17 years after this was the law was put into place in the Netherlands that you actually got the sort of 1 in 33 deaths that now occurs because of euthanasia, of which a fair percentage of those is euthanasia without consent. So you really have, I think, what you'd call a culture of death happening in the Netherlands. And it's 17 years after this. We haven't, Oregon is a tiny state. It's got 2% of the population, as I say, and the numbers are fairly not going up massively. I concede that. But I think you need to see what happens when an entire culture of death happens, and when death is medicalized and suddenly it's a treatment for various different parts of life skills. What you tend to find is if it's a treatment, it's only, you can't deny it to anybody. How can you deny medical treatment to somebody who needs it? And so therefore you're seeing all of these various different cases come in the Netherlands and in Belgium, and that is what is occurring there. So, I mean, as Theo Boer pointed out, he's now very much against legislation, legalization. He points out it's taking the genie out of the bottle that's the problem. It's not a slippery slope. I agree that it's not a slippery slope that we face. It's taking the genie out of the bottle. It's that quick, slippery slope, moral precipice would be a better way of putting it. I think it's that crucial first step of legalization that will actually create the problems. I'll stop there.
Okay, thank you, Kevin. There's a huge amount to draw on from both those contributions. I'm very interested to come back to the question of autonomy, though, to get both of your reflections on what the limits to it are, and if any, where do we draw the line, and how do we prevent what Kevin's saying about these kind of categories into which people can be put based on an inability to be clear about what you mean by the definition of, or the limits of it, or would you have
a question for me?
Well, kind of, yeah. Well, it's really a question for both.
Okay. I think it is the toughest question about, well, how do you draw lines? Because you have got a spectrum of possibilities, and you have to make an arbitrary decision about where you cut it off. But I think people do understand this. I'm just looking rather vaguely for some figures I've got here. That 82% of the public in the UK, for instance, support Faulkner's version of assisted dying, but only 40% support assisted dying for non-terminally ill people. So the public understand that there's a difference between the two. And I think there are a couple of examples that make it easier for us to understand how you can make an artificial division along what's actually a continuous spectrum. One is free speech, for instance, that we all want free speech in society and think it's our right and it's very important. But also there are laws to say you can't stand up and incite racial hatred, which is one end of that spectrum. So even with free speech, you put a guillotine down somewhere and say, okay, so free speech is really important, but actually at that point we're going to say that you can't have it because we think that the disadvantages are greater than the advantages. The same thing had to happen with abortion in the UK. Somebody had to say, okay, here is the cut-off point for abortion, and that you can have it up to this point and not after. So it's always going to be arbitrary. And the fact that people in the UK will support the basis of Faulkner, terminally ill, mentally sound and all the rest of it, but don't like it, the figures really fall off once you say, well, would it be okay for anybody? It means that probably the difficulty of putting an arbitrary cut-off on it has been made in the right place, that people understand why it's there.
Okay, thank you. Arguably, when the guillotine comes down on free speech ceases to be free, and so is the same true of autonomy, or is that? Could you expand on what you were talking about the categories that we risk making or devaluing, if you like?
Well, I think the problem that you have is that once you say this is a medical treatment for people in this situation, what it inevitably leads to is other people coming and asking for the same medical treatment. And I think it's, this is what you see happening in Belgium and in the Netherlands, is that people are saying, well, look, I am suffering, I may not have a terminal illness, but I'm suffering very awfully. And how can you tell that? I mean, the problem with suffering is that it's entirely subjective. Mm-hmm. A doctor can't actually prescribe and say, you know what, you are suffering this much and you are not suffering this much. It's a very subjective thing, and I think it's rather patronizing in some ways for us to say your suffering doesn't count as much, therefore you're not in this category. I think that's the problem, is that you have this inevitable problem, which is that people will go to their doctors, they will go to their GPs and say, I am suffering from this all of the time. And the process, I always think it happens, it's a bit like when people go to their GPs and say, I need these antibiotics, and they just pester their GPs until finally they get them. I'm not saying that there's an exact correlation, but I can imagine that in the Netherlands and in Belgium, people are saying, my suffering is real, it's profound, I've had this wish for a long time. This 24-year-old girl has said exactly that. And doctors are, and in fact, the 24-year-old's parents are both in agreement with the whole thing as well, which is makes it a fairly unusual case. But at the same time, it points to the fact that how can you deny somebody who is in desperate need of, or thinks they're in desperate need of this, and say to another person, yes, you're able to have this. I just don't think it's possible to draw the line.
Can I respond to some of those
Yes,
points?
please.
Yes, thanks. First of all, I think we have a difficulty here, which is inevitable between us, because we're not even comparing apples and oranges in what we're talking about. We're talking about apples and cabbages here. You're constantly quoting what goes on in Belgium and Netherlands, and I think many of us would not subscribe to what goes on there. I'm talking about what's on offer in the UK at the moment, and underlined by the fact that the law you pass is the law you get. And there have been no examples of anything like that. So I'm not here to promote euthanasia, the Belgian thing about children. I'm here to speak about Faulkner's law based on the Oregon experience. There is no inevitability in that. It has not been shown. There has been no mission creep in Oregon. And Oregon may be small, but they've been so successful that it's been adopted by Washington, it's been adopted by Vermont, it's been adopted by, I can't remember the other states, it's under consideration in other places. Petitions have been put in other places. The Canadians have just moved to neutrality. It has shown that this can happen safely. I think Faulkner absolutely is objective. It's very objective. You have to fit these criteria. It's not, oh well, you're suffering, that's bad luck. People will continue to suffer. There are people like Tony Nicholson, if anybody followed that case, who had a brainstem stroke, had to starve himself to death in the end because he did not, even under Faulkner's bill, he wouldn't have fit the criteria. So you're never going, but what I'm hearing is that because some people will continue to suffer, all people will have to continue to suffer. And I'm saying, actually, we can take a tranche of people out, very clearly identified, 6 months to go, terminally ill, sound mind, settled intention, and say, we can stop you suffering. And I'm sorry, new people aren't going to fall into that because society doesn't agree with the position that we can offer this to anybody who's suffering. So it really is, can we stop some people suffering? And is an argument that we can't stop everybody suffering an argument that we won't let anybody cease their suffering? And I would say better to take out those people than to say because we can't do it for everybody, we'll do it for nobody.
Can I come back on that?
Please do.
Well, I mean, first of all, with Oregon, is it Oregon or is it Belgium or Holland? There's a good article in the Spectator today by I can't remember who's by, but he makes the point. Are we going to look to this tiny little state that's always been fairly independent and sort of out there, and not only that, but used by a sort of a showcase state? Because I mean, within the last few months, there was a proposal to extend 6 months to live to 12 months to live. It was thrown out not by those opposed to assisted suicide, but by the people in favor, because they said, well, that will mean we will have to, they were under pressure from Compassion and Choices, which is the sort of equivalent of Dignity in Dying in the United States, to stop that. Why? So that it could continue to be a showcase state. There have been over 100 attempts to legalize assisted suicide in the United States, of which 3 of those have been successful. So it's not by any means a battle won. They're making that a showcase so that they can say, yes, there's been no problems here at all. I think it's much more realistic to look to an entire country where a culture changes. And what you can see about, for instance, the Netherlands is that unlike almost every other country, doctors favor legalization of euthanasia and assisted suicide, whereas in every other country I can think of, doctors are in general opposed to assisted suicide. And in actual fact, palliative care doctors are almost completely opposed. 90% of palliative care doctors in the United Kingdom are opposed to legalizing assisted suicide. And whereas in the Netherlands, there's much more a cultural of acceptance, and this is something that I think we should be concerned about, of death. And I think it's much more realistic to look to a country just across the water that shares similar liberal values as we do, that has very similar characteristics. Even the legal basis is not that different, unlike the United States, where there's various different states. And I think it is much more realistic to do that. I'm glad you brought up Tony Nicholson, because one of the interesting things about drawing the line is that there are many people in the United Kingdom, for instance, who don't fit the criteria because, for instance, Tony Nicholson suffered from locked-in syndrome. It's called locked-in syndrome, where he was paralyzed and could only move he could communicate, but he could do very little else. He wouldn't have fit those criteria at all. So effectively, if you pass the law, you'd be saying you need to suffer because you don't fit these criteria. There's no moral basis for making those decisions. You can't say one person's suffering, Tony Nicholson's suffering is somehow less than somebody with 6 months to live. And what I say is that that's going to erode that line, because more and more people are going to say, well, if we're providing it for them, why don't we provide it for those? If you define it as medical treatment, how can you deny it to anybody? And this is happening in Belgium. They've actually said, well, why should children have to suffer? So they've now allowed children to have voluntary euthanasia in Belgium. And I just don't see that you can keep that line going. I don't see that there's any moral basis to do so. And if you legalize it, how are you going to, and I will hope people do answer me, how can you actually deny somebody in this situation if you're doing it on the basis of suffering and not in that situation?
Well, I would only say the same thing I said already.
Okay.
I think it is important that people simply can't stand Oregon because it's worked for 18 years. There's a very telling thing happened, which was that when the law was passed, as I understand it, the Oregon Hospice Association, and Kevin's quite right, the palliative care doctors are overwhelmingly against this because it's kind of an insult to them. It's them saying, well, actually, you can't relieve all suffering. And we're doing a survey at the moment to find out what percentage of suffering is unrelieved. And it's also true what you say, that it's not all about pain. But I watched a member of my own family who was given a diagnosis of terminal inoperable cancer, 3 months to live, spend 3 miserable months fearing their death because they were that generation to whom dignity was everything, actually. And they feared the loss of dignity, and by that I mean real basic things like incontinence. And that happened to that person, and I watched their misery, not from pain because they didn't have pain, but from being doubly incontinent and having to deal with that. So who are we to say that's less of a reason to want assisted dying than intractable pain, which some people get? But people don't like Oregon. It has been successful. It has been adopted in other places. I would challenge one other thing. Most doctors are not opposed to this, and I'm afraid the British Medical Association, I sit on their council, have what I would characterise a dishonest position, because they have refused to survey their members, which in an electronic age would be a very easy thing to do. The Royal College of Nursing have done it. They refuse to do it because I believe they will get an answer that they don't like, which would force them to move to a position of neutrality at the least. And a big survey done recently, the biggest one that's been done of doctors, as I said, showed that most doctors were either pro or neutral and wanted their bodies reduced. So when people say most doctors are opposed to this, it isn't true. It isn't true, and a lot of doctors have wanted for themselves too.
I want to go out to the audience shortly, but just before we do, I want to just come back to the topic of dignity. I'm interested in how this weighs in the discussions around assisted dying. Are we, what sort of death do we judge implicitly to be undignified? This is a question obviously for both. But,
I think only the person can decide that. Only somebody can say, this has got to a point where I can't get out of bed, they're having to change me, doubly incontinent. This is intolerable to me. And that is not, I don't think that's something we can judge. That's why I don't think it is for doctors to judge about assisted dying. I think it's for society to judge about assisted. Of course, the terminology is very interesting. I want to come back to that for a minute, the suicide versus dying thing. I came across something the other day, that the people who, do you remember, I don't know whether you ever saw films of it, it was absolutely dreadful, that when the Twin Towers happened, and those planes hit the Twin Towers, people jumped off the top. I mean, a lot of the deaths below were killed by people jumping off the top. The people who jumped off the top. I mean, they killed themselves, but they were judged not to have committed suicide. That was a decision that was made at the time. Their deaths weren't recorded as suicide because it was felt that they had no choice about what they did because they knew that something terrible was about to happen to them. And I would say the same thing to you about people who take the medication when whatever happens to them, they feel they become so undignified, their life's not worth living anymore, or their suffering becomes great, and they know they haven't got long to go. But that is a choice that is pejorative to label that as suicide. That's a choice they make at that point. And I think suicide, calling it suicide, brings in all sorts of arguments that are not pertinent in this situation.
Well, I mean, we can get all Orwellian about it and decide that, somebody sitting in a room giving them, that's a different situation. That's a considered thing. That's not a sort of panicked jump out of a window or anything else like that. That's somebody making a very considered decision and being given a cooling off period. So that is a decision that they're making, and they're sitting in a room taking poison. We'll have to really rethink the whole definition of suicide if we're going to say that isn't. But anyway, on the dignity thing, I think that's very interesting the way you put it. You can't, you're saying that you can't judge somebody's definition of dignity, but we are by putting that sort of 6 months to live. Dignity is defined as dying if you are in that particular sort of situation. You're actually, defining it as dignity, as dignified. Yes, it's a very subjective thing, but you're giving physical criteria where you're saying this is a dignified death in this situation. Presumably, we're saying that suicide with more than 6 months to live is not dignified, and so that's not a dignified death. So, we are changing, we are judging these kind of things. I would also say that one of the reasons that disabled people are so opposed to this legislation is because many of them are doubly incontinent, and many of them lead useful and productive lives, and they don't want to have somebody saying, your life is you fit these criteria, and therefore we will allow suicide for you. We will put all these sort of suicide prevention issues for anybody that's not in that situation. But if it's horrible to be doubly incontinent. So disabled people object on that very basis, and that you're immediately condemning their lives as not being dignified, which I think is very wrong.
Can I just say that in fact 90% of, I think it's 90% or 89% of people, disabled people, think there should be legislation for assisted dying.
I would dispute those because I know that survey, and that's one carried out by Dignity in Dying. So I think the reality is completely different. There are different, the problem is you can pick your polls. Let's face it. It's how you ask these questions, and it's who you happen to ask. In general, all the disabled organizations that I know of, except for the one that is within Dignity in Dying, Greg Judge effectively, are opposed to legalizing assisted suicide. And the Not Dead Yet UK, you will find, will be one of the most, and Not Dead Yet Ireland and Not Dead Yet the United States are the biggest opposition in some ways, besides religious opposition to assisted suicide. Yeah, that's it.
Okay. We have a roving mic, Brett has, for questions, and very keen to hear anybody's reflections and questions on this topic. If we can just kind of circulate it along, I think you have to press the red button while you're talking. What we'll do is we'll take a number of questions and come back to our speakers to let them respond to whatever they want to respond to. But interested to hear anything at all. So, Jason.
Hi. Different questions for both speakers. First of all to Kevin, because you're a historian. For most of the 20th century, certainly the post-war era, this has been very much a fringe issue discussed by philosophers on an incredibly abstract sense about rights-bearing subjects and perhaps medical ethicists and so on. Why do you think it's become a living political issue now, and do you think that there's some sort of cultural or moral change? And to Jackie, slightly tougher question, I fear, but you mentioned that I made a comparison to the situation with backstreet porches in the UK. Very briefly, I'm not sure that it's necessarily comparable, because we all know that doctor-assisted suicide or doctor-assisted dying does go on behind closed doors, as you put it. I'm not sure why that's so terrible. So why do we need legislation for this? And whatever one's position on abortion, I think you have to recognise that, and I should lay out that I am pro-choice, but the anti-abortion argument in Ireland has stated that the UK's 67 Abortion Act has led to abortion on demand, and they're correct, it has. That argument has to be conceded. In fact, it not only has led to abortion on demand, it also forces women to humiliate themselves by lying and saying that they're mentally ill in order to obtain an abortion. So I think there is, if there's any comparison to be made, I think you do have to accept the concept of a slippery slope, or as Kevin put it, a moral precipice.
Thanks.
Hi there, and thank you very much for your talks this evening. I absolutely agree with you, Kevin, that it's very difficult. That it's very difficult to draw a moral line saying that we will relieve suffering for these people, but not for these people. And so that's why I think the Oregon case is a very good exemplar to take, because it makes not a moral line, but a legislative one that grant suffering to people who have been diagnosed with a death within the next 6 months. And coming in this evening, you might have seen my hand earlier as somebody who does believe in assisted dying. And a view that I'm keen to hear your opinions on is that of living wills, that setting that legislative line even further back to, as you say, recognise suffering that is not terminal, but if I make a sovereign decision, compos mentis today, that I do not want to find myself doubly incontinent, or whatever criterion I feel is inappropriate to my quality of life and appropriate to having a dignified death. Is that something that should be legislated for?
Thank you. Can you just pass it over?
Thanks. I'm coming from a position of somebody who has worked in specialist palliative care for the last 22 years. So I reckon I have seen a lot of people come and go, and I've heard a lot of people's wishes. Something that I would see recently, obviously it's probably going on in the UK a lot longer, is this notion of palliative care for all. And certainly our services are burgeoning with people being referred with all sorts of end-stage cardiac issues and respiratory and renal and whatever. And there is no doubt that there are a certain number of illnesses where the prognostic trajectory is quite finite, and you know that there is an absolute end line, and you know what the symptom control will be. But I've also been with the people who have these awful neurodegenerative disorders, who their own consultants, by their own admission, will say that the day they see them in outpatients is the best they will ever be. People who lose the ability to scratch their nose, never mind the continence thing, they can't feed themselves, they can't whatever. So in listening, I'm somebody who put my hand up because I believe people should have the right to make a choice about the death that they would want to have. But it kind of scares me to hear Kevin, to hear your side of the debate, Kevin, because it almost sounds like a Mac drive-by die. You know, that this notion of once it's brought in, because I believe however it's brought in, it will be absolutely bulletproof. I think same as within the Netherlands, it's going to be so hard to actually access the right to a death that a lot of people could spend the last few months of their life fighting in the courts instead of having any quality of life.
Thank you. Anybody else? It's gentleman here in the back.
I thought it was interesting, the example of September 11th and how some people chose the matter of the death. It does seem to be an illustrative situation that maybe you could talk about, if people, should they have been allowed to choose the matter of the death, to
plummeted to death rather than being burnt alive. Sure, this tells us something about people who don't have as much control over how they die as others. But why can we? What gives us the right to deprive them of that right?
Thank you. There is an immense amount for both of our speakers to come back on there, actually. So, very, very provocative questions all. Kevin, I don't come to you first, actually.
Okay.
To answer,
I'll do it in order, if that's
Yeah,
okay.
absolutely.
But I'll forget something. So.
That's inevitable.
The question about history, why now? I think you asked me a history question. This is dangerous to do, I have to say, in this context, because I think it's a fascinating question because the organization that probably evolved into Compassion and Choices could not keep an office open in 1960, and yet by certainly by the late 70s, it was a multi-million-dollar funded organization with huge full-time staff. Even Dignity and Dive has 5 full-time publicists working for it, and it's quite well. And the question is, how do we get into that particular situation? I think a lot of things happened in the 1970s that it's related to. I think probably the most interesting, it's almost like there's an attack on, or there's a disenchantment with health technology that takes place at that particular time. A lot of people say, oh, it's happening now because technology has gone so far that we can now live forever, which would be great if we could. It's not really the case at all. I think it's because people take this different attitude towards the technology of health, where they see it as an enemy rather than a friend. It's something that's not going to help them. It's going to make them live too long, and that they feel out of control. I think there's that sort of sense of feeling out of control of your own life, and that medicine is continuing along and forcing you to do things that you don't really want. We don't have the same attitude towards medicine that we had in the past. Much as I think there are good elements of the sort of old-fashioned paternalism, I think it's a good thing to have got rid of at the same time. But I think that is a change that we have to have reckoned on. I don't know whether that, I can go into this for a very long time.
Well, just briefly, what I'm driving at is was there when you found out that countries like Sweden, for example, had named the eugenics programs and stuff until 1980, it horrifies us because we immediately think of the Second World War, the Nazis. And I'm wondering, was there a cultural legacy or hangover from the post-war period that is now passed? And we now think, and against you, I mean, we're not necessarily taking your side, so against you, would it be that there was some kind of hangover that we've now got over and we can actually think about this issue?
What happened in the 1970s is the right to die. It became an individual concern. We became much more individualist, the me generation, et cetera, et cetera, et cetera. And so therefore people talked about the right to die, whereas 10 years before they talked about voluntary euthanasia, and it was much more with the interests of society at heart, particularly in the 1930s when you had the beginnings of the voluntary euthanasia society in the UK and in the equivalent one in the United States. They both arose to try and improve society by getting rid of defectives. That's why it originally occurred. They have moved away from that in the 1970s. They moved away from that after the Second World War.
Sure, that's what I'm getting at. I'm saying, is it not arguable that that's an improvement because we were seeing this issue in absolute moral certainty terms, whereas now we're actually willing to consider individual cases? I'm just asking.
No, I don't think it's an improvement in the sense that the right to die is very illusory. There's no such thing as a right to die any more than there's a right to be affected by gravity. It's something that we all do well enough, and people have been doing before doctors got involved. We are all going to die. There's no question there. And I think the right to die is a sort of the right to control, all of these various different things. I think it's actually a sort of societal fear. If you're asking me with my historian's hat on, I think it is much more about sort of the fear. People are much more survivalist in these day and age. And one of the ways that you can survive, one of the ways of getting rid of everything, as Isaiah Berlin said, getting rid of everything that can possibly hurt you, the inevitable conclusion to that is suicide. That's the only way you can do it. So I think there's something to that. But I mean, that's like lectures and lectures and lectures. So I don't want to go too far onto that. But there was also there's a discussion about backstreet abortions and sort of, are there backstreet suicides and backstreet abortions. I would just make one point that if we, as Jackie rightly pointed out, if we think about 332, that's their estimate, the Dignity of Dying's estimate of people who are now committing suicide who are terminally ill. If the legislation goes through, based on the figures in Oregon, that figure will treble. We will have 3 times as many suicides in terminally ill people as if we put through this legislation. I don't know, you need to think about whether that's a good thing or a bad thing. Some people would say that's good. I don't think it's a good thing to have more suicides, even in people who are terminally ill. I just think it's an interesting. I also question whether it's such a good thing. People talk about, I think Jackie mentioned a few times this sort of what's happening behind closed doors. I think death should be a fairly private thing. I think we don't need to kick out a priest from the deathbed scene and invite in a lawyer. That's what I see this whole process is doing. It's officializing, it's shining this legal spotlight. So it's going to make it much more difficult for doctors to actually take those humane decisions that they need to take in some situations. It's going to have this legal spotlight shone on the whole deathbed scene. And in Oregon, it's quite spooky actually. In 1 year, 2013, I believe, where there were 54 deaths, 52 of those deaths were attended by volunteers from Compassion and Choices. There was a great boast. And I'm thinking, I'd be happier to have a priest as an atheist. I'd be happier to have a priest than some creepy person that likes watching people die. It seems a very, very odd thing. I don't think, I think there are times for shining, transparency. I don't think the deathbed scene is one of them. I think it's something that, you want to have your goodbyes, you want to have your bona fide emotions, not sort of for the camera or anything else like that. You want to have, regrets, you want to have all sorts of things expressed. I don't think it's going to be helped by having people, officials sit in to make sure that these safeguards and ticking the boxes and everything else like that. So I think there is an element of lack of privacy about these things. Okay. There's another question about
Living wills.
living wills. Very interesting question about the kind of living wills question, simply because it points to where like if I made a pact with I can't remember who asked that question. If I made a pact with you and said, in this circumstance, I want you to kill me, the moral peril would be with you and not with me. It's a very difficult thing to do. It obligates somebody else to be taking this action. So one of the problems that they've had with living wills is that many people say, well, if I'm losing my marbles, I would like somebody to kill me before I completely go. If I'm suffering from, what's the disease that I'm thinking of? This is dangerous, actually. Sorry?
Dementia.
Alzheimer's. It's not a good thing to forget. But if I'm suffering from that, I want you to kill me. And yet you have the situation where the person, there's an interesting case in New York where this woman suffered from dementia, read the same detective book every night, and enjoyed it immensely, and ate ice cream. Are you going to be happy to kill a person in that particular situation? And I think that's one of the sort of real difficulties that you have with the living will.
question? So we're taking a case where there's already something equivalent to the Oregon law in place, where let's say that there's a clinical threshold, that it's not a matter of subjective judgment, but I have drawn this document up with my lawyer, and in the event that I am doubly incontinent or whatever clinical diagnosis, so there's no discretion involved, and it's a state agent who's going to be doing it, just as is the case in Oregon. So abstracting from your scenario where there's any moral culpability or any legal culpability on the person doing the killing, would you deny me the right to assert a sovereignty over the quality of my own death?
What I would say, the problem with what you're saying is that you're assuming that, for instance, there's two different scenarios. If you said, I would not want to be fed in these particular circumstances, that would mean I'm not causing your death, necessarily. That's one situation. And it's another situation where you would say, I want you to kill me. And I think the moral peril is on the basis of the person who's killing rather than the person being killed. The person who is dying is wanting to accomplish that act by whatever way necessary. It's not going to make any difference to the person dying how that act is actually done. It's going to make a big difference in terms of the person having to do it. So I would distinguish between the two situations. If you said to me, don't feed me, I think that's reasonable. I think people should have the right not to accept treatment that they don't want. I think that's a very important right, and I would very much support it. But if you said, kill me, I would refuse to kill you. I hope that's clear. Interesting question, a very good kind of question. Yes, exactly, it's not the same thing. September the 11th.
We'll take note.
There's a certain ambivalence about what the man is saying.
What I'll ask you to do is actually to park the question and we come back, because Jackie hasn't spoken in a while, so I'm conscious of that.
Yes,
so thanks.
Monopolizing.
No, go ahead.
Interesting question at the back, although I would say that's a situation, the September 11th thing is a situation where you have no choice. That's a Socrates kind of issue, where they say, are you going to drink?
They had the choice of how they wanted to die. Some people they chose to jump out a window rather than being burned alive. They had a choice.
Yes, exactly, but the situation isn't the same in somebody who has a certain amount of time left and is choosing to purposefully
I'm choosing
commit
to
suicide.
die according to how I wish to die, rather than in a situation where I have no control.
Yes, and in some elements, I would like because people ask about these kind of issues of suicide, and I would defend somebody's right to take that action themselves on somebody. You were talking in terms of rights,
Provided they're able to.
Well, I mean, who can't refuse treatment? I mean, Tony Nicholson even refused to eat and drink and was dead in less time than it would take for the cooling off period that's been proposed in the legislation.
To kill themselves and to deprive the right for those people.
I'm saying assistance. This is legislation about assistance. It's not specifically about killing yourself. I would defend, in some ways, like I'm writing a book now on suicide, and one of the chapters is in defense of suicide, which sounds completely contradictory, and I shouldn't have brought it up because it'll confuse you all, but I think it's important that people do have, the right to self-determination, in the sense that there's no right to suicide, because of course it's not something that you need to have a physical right to do. It's something that physically just about everybody can do without a right. It's confusing to talk about it in terms of rights. But I think the two situations aren't that comparable, because basically if I put a gun to your head and say, you can either jump out that window or I'll shoot you, that doesn't really leave you with a choice. We're talking about this situation with a real choice. People are making this choice. It is a specific choice that's being proposed in the legislation.
Okay, thank you. Obviously, these cross-panel floor discussions are inevitable. I don't want to discourage them, but I do want to hear from Jackie as well on these questions.
God, I've got so much scribble in front of me that I don't know that I can make any sense out of this. I think the Twin Towers thing is pertinent, actually, because if it's wrong to kill yourself, it's wrong to kill yourself. They kill themselves, but we'll park that for a minute. Behind closed doors, I think, is a really important question, because I don't know whether Shipman made it over here, did he? Harold Shipman. Okay, Shipman is what happens when you're behind closed doors. Nobody knew what Shipman was up to. He was bumping people off in industrial quantities, and people didn't know what was going on. So it would bring that sort of thing out from behind closed doors. I went to listen to the fortnight debate in the House of Lords, and person after lord in opposition stood up and said, "Oh well, of course the doctor will see you right." Well, that is a very dangerous situation, because by the time they've seen you right, the patient's dead, and who knows what anybody wanted in that situation. Whereas under Faulkner, you've got to have 2 doctors, a psychiatrist if necessary, and judicial review now. So it's right out in the open. somebody in my family who's a doctor prescribed a normal dose of morphine to a dying patient who wouldn't go into hospital. They had terrible sacral bed sores, pneumonia. They wouldn't go into hospital. Went back the next morning. The patient was dead, and everybody thought it was a mercy. The patient lived on their own. That GP was arrested in his surgery, had his bootlaces and his braces taken away, was suspended from working for 2 years while he was investigated. And after 2 years, the GMC, who moved very, very slowly in the UK, after autopsies and toxicology and all the rest of it, they said, you have no case to answer. You gave that patient a normal dose of morphine, and the relatives had accused this person of killing the patient. So you've got two things here. You've got people perhaps slipping patients large doses of morphine, or where morphine doesn't always work. Anne Macpherson, who started HPAD and died a horrible death of pancreatic cancer, became resistant to morphine. They couldn't kill her with a morphine drip. She had a miserable death, and if you doubt it, go and read the article in the British Medical Journal, written by her daughter, who's also a doctor. So it's not that easy. And then on the other hand, you've got cases like the one that I'm describing, which got a lot of coverage in the medical press in the UK, and GPs began to be afraid of giving appropriate doses of morphine to people, which is why palliative care for everybody is so important. And of course, we want everybody to have the best possible death without having to take this, but it can't be done for everybody. I mean, we know that as doctors and as people who work with those patients. I've heard a couple of odd things from my colleague here. It's a bad thing that we should offer assisted dying, but it's also a bad thing because not everybody can have it. So I find that a slightly strange argument. I thought your comment about this, that it's scary, is very important, because that is what happens. People try to scare us on the basis of what's not on offer, and I think for those of you who are listening to the apples versus cabbages, you have to decide whether you accept that what's on offer in the UK is apples and not cabbages. And of course we can, the interesting thing about Holland actually, where we've heard all these scare stories from, 92% of the public in the Netherlands support the law 10 years down the line, and they know all these stories as well as everybody else. 92%, and 97% are confident in their GP. So the Dutch are actually, whether we like what's going on over there or not, the Dutch are actually quite happy with what's on offer. Judicial review, somebody mentioned, would this be inexpensive? Would it make complicated at the end of life? You know, I'm a paediatric radiologist. I've seen, for instance, children come in who are the children of Jehovah's Witnesses, where quick decisions have to be made about blood transfusions and that sort of thing. So the law is set up to make very rapid decisions if need be. And extrapolating from Oregon, they reckon it would be about 2,000 deaths a year in the UK. I heard the interesting figure again about trebling the number of people who committed suicide. It's a figure that people use about Oregon a lot. I think when it was first offered, the figure went from 17 people who took it, and as it became known that it was available, it went up to 64. So in reality, it did treble, but in actual figures, it was a very small increase, and which hasn't gone up since then. Why now? I think because society is increasingly secular, that the arguments about, the religious arguments about whether assisted dying is right or wrong are softening. I think people are used to patient choice, to choice in their lives, and they're saying, why can't I have a choice about this? This is really important. Why are you being paternalistic to me? And I scribbled down lots of other things. You know, why shouldn't Oregon be a successful showcase? I mean, why should we be knocking Oregon on the basis of the fact that things have worked there? And it's now gone to Vermont, and it's gone to Washington, and they're looking at it in all sorts of other places. So I think it is an idea whose time has come. I think doctors are being honestly moving to a position of neutrality to allow society to decide about this. And personally, I believe it will happen, and in 10 years we'll look back and say, how did we ever have a situation where that couldn't be the case? And that people's absolute, perfectly reasonable fears will be laid to rest. And of course, built into Faulkner is the ability to review it every couple of years. It's what's called a sunset clause. So you can look at it and say, actually, we don't like the direction it's going in. But there has been no mission creep in the places who've adopted Oregon.
There was one other, before I go back out again, there was one other element of the question which brings in, I think, a lot of, well, actually both of you in your initial address were variously sceptical about the slippery slope argument, yet at the same time it's possible to make an argument that the culture of death, moral precipice, inhabits a similar kind of I was wondering if you could tease that out a little bit, because I'm interested myself because it's such an arresting phrase, a culture of death, and I'm wondering if we can expand on that just a little before we go out again, take audience questions.
Well, on that very specific question, I suppose it's, to me, I don't like the slippery slope because it implies that, well, these people are legitimate and we should allow this to happen for this particular sort of group. We're going to separate this group off from society and say, you know what, suicide's absolutely fine for you. It's entirely legitimate, and we'll remove all moral, any kind of moral implication. This is what behind the sort of name change. So I object to it because I think, like capital punishment, I don't think you can just have a few capital punishments and that's okay. I think you either decide that the whole idea of capital punishment is wrong, or you, or execution, or whatever you want to call it, or you think it's a legitimate thing and should be used in society in a limited sort of way. So, to me, the part about the slippery slope that doesn't make sense, and this is probably one of the few places we agree, is that I don't think they're sort of killing off people in Oregon, or willy-nilly. They're not sort of. It's not full of shipments. I don't think. I think you're a little bit cynical with doctors. I trust doctors. I think most people have a humane interest in helping people. I think that's why doctors actually do what they do. I think they want to do the best for the patients. And I don't think, I think shipment is a massive irregularity. I don't think we've got there's not, it's not like you're all Mengele's waiting to kill off patients. I really don't think you are. So, yes, I think, I can't remember where I was going with that. Yes.
I think the capital punishment argument, I have to say, I don't really see where it comes in here.
Are you in favour of capital punishment?
No, I'm not in favour of capital punishment. I think capital punishment is something that's done to people who don't want it, and I think the essential thing about assisted dying is done to people who are asking for it.
What about the 11% who do want it? 11% of US capital cases do want to die. So should they be allowed to?
No, because they don't fit the criteria for that. This is very.
So it's not really about autonomy, then, is it?
Well, I think I've been through this.
Or choice.
Try to explain about autonomy and choice. That there is a whole spectrum, and a decision has to be made. This is the point at which we'll say that society will benefit from this, and on the other side of it, we think that the pros outweigh the cons outweigh the pros. And the figures that I quoted show that actually people get that they will support Faulkner, but they won't support assisted dying for long-termly ill people. So I think society understands that. So I still say I don't understand where capital punishment comes in. I'm not cynical about doctors. I'm a doctor, hands up, declaration of interest. I think 99.99% of doctors are absolutely want to do the right thing, but I think trying to do the right thing when the law is a fudge at the moment is very difficult, and it allows something like shipment to happen. I am not saying society is full of shipments, I'm saying shipment got away with it because we're living with a fudge at the moment, and it would be much better not to live with a fudge.
There's an immense tension between the moral and legislative approaches. Actually, that came up in one of the questions. But I know there are at least one person who wants to ask a question, possibly more. I guess
I've just a point for the chair. I think that if we're going to have another set of questions asking what we're in favour of, I think we should have a question: are we in favour of apples? Or we're in favour of cabbages? Because I think I appreciate the question being asked at the beginning. But the reality is that there are two propositions being put forward, and I would definitely not vote for cabbages, but I'd definitely be in favour of apples. So I think it's important to have a vote, and asking that question, that would you be in favour of a Belgian system? I would be, or the Netherlands, but I definitely would be in favour of an Oregon system.
Why, would you, what is it about Belgium and Netherlands that you wouldn't?
Because I feel that there is an issue in terms of, I don't believe in absolute moral values. I believe that values are buttressed by different values, and different issues have to be taken into account. So my issue is that I think that in terms of, I believe, for example, in autonomy, I think autonomy is an essential principle in this decision-making process, and I feel that once you remove autonomy from the issue of assisted dying or assisted suicide, you move it down into an area that I'm very uncomfortable with, because it's not me making the decision, it's somebody else making the decision, and that's the problem I have with cabbages.
Right.
Well, I quite agree about cabbage because I prefer apples, I have to say, to cabbage. I don't like cabbage.
Any other questions about either of you? Gentleman at the back.
So Jackie mentioned there how judicial review would be one of the protections of judicial reform type law. Now my concern with that would not be about the cost of it or how time consuming it might be. My bigger concern would be that we're putting yet another area of public life into the hands of the judiciary. We have life and death decisions being taken by unelected, unaccountable judges. I'm just wondering what the speakers view on that.
Okay. And at the front here?
Yeah, I'm just wondering whether it should be called the legalisation of assisted dying debate, because it seems to me that the premise of this is not that you're anti-assisted dying or suicide per se, but it's the fact of it coming into law that you've issued it. So I think part of what you've been saying is at loggerheads because of that. It's the legalisation of it, isn't it? Am I right?
It is. That's the truth.
So it's really it's not like let them suffer, until. But it's about some system that you're obviously you're very pro, because you think it will establish certain criteria that will stop bad things happening, and you're anti because you think it'll set in criteria that will not allow for a flexibility that may already be there. And I think it is interesting, words like closed doors suggest something very ugly, whereas you can say private autonomy and that can sound very different. It's really like whether you put it in Gothic trappings or happy rainbow trappings, or there's a lot, and I think you're very right about the fudging thing, and it's troubling, but it's not necessarily, fudge isn't necessarily bad per se. I know it's cabbage.
It's even better than apple.
But I partly agree with the bright light thing, but actually my question was that I looked up the different phrases for, because I assisted dying in your book is assisted suicide, so and I was thinking which I would call it, and anyway I won't tell you, but you can probably guess. But I've just written down off that great source of human knowledge, Wikipedia, some different euphemisms or names, if you like, for what we're talking about, and I just want to list them to you, and for basically what you think of them, because I think that there's a lot of the ideologies, the beliefs, the morals can be found in the language, things that are the language that's decided to be used and what's not being used. In other words, like the pro-legalising of assisted dying don't like the word suicide, and they prefer the words dying and death because they sound more natural, and they deny any intervention on the medical side. But anyway, assisted suicide, physician-assisted suicide, physician-assisted dying, physician-assisted death, aid in dying, dying with dignity, right to die, compassionate death, compassionate dying, end-of-life choice, and medical assistance at the end of life. And I think each one of them, I know you're not going to remember them, or maybe you know them already, you're not going to be able to go through them, but each one of them, even if we just want to talk about the language that we've all been using here, about words like dignity and suffering, we won't even get beyond our word choice, let alone our moral and philosophical issues. But I think words shape our philosophical and ideological, so I think they're worth looking at. My biggest one is words like compassion and rights and dignity. And I get very hepped up about these and how some people curtail them off to their side of the argument. And so I basically that's my question, is what would you make of the language that's used to describe what we're talking about?
Okay, very good. Thanks. Any others? I just wanted to come back to the question addressed to the chair directly. I mean, it's true. I think it's important to probably try and find what the particularities of the respective legislations in Oregon and Belgium and the Netherlands and so on. There are still things that are common to them, and I suppose that's broadly speaking what I'm asking people to consider by way of legislation. And one of the things, to pick up a phrase that you used earlier, the privacy of the deathbed scene. Because whatever system that we're talking about, there is a fundamental change in the way that that is viewed, and a fundamental change in the way, as we've discussed, that autonomy is viewed. So I think that there are things that are common to it. I mean, I could take a respective, perhaps I will take a respective poll about, let's say, Oregon versus Belgium at the end by way of, out of general interest, but I still think the initial question probably holds. Thoughts on any of the above, Kevin?
Yeah, I mean, just a few things that I definitely want to come back on. First of all, on the law, because somebody's brought up, the law. What about this law? I think the law is not doing a bad job. I mean, Jackie's talking about that one situation, but what I can absolutely assure you is that in the UK, nobody languishes in prison for assisting somebody else to die. The law has been used a handful of times since it was first passed in 1961. And basically, the people who are prosecuted often do everything but run naked past a police station giving a B sign and saying, I've killed somebody, I've killed somebody. Most of the time, if you keep a private situation and everybody agrees that this is the right thing to happen at this particular time, the law covers situations where, for instance, there's a situation, there's somebody who's in prison now for killing her son who is in a coma, and she felt that he was suffering too much, and she broke into the hospital room and killed him, and that's where the law has been used. I think the law is doing actually a pretty good job. I don't see that fudge, much as I love fudge, I think the fudge that we're talking about has not resulted in any great disasters at all. I think when doctors need to take this decision, I think it's best to have as private a situation as possible, and for the doctor to be able to take the situation immediately and not have a 2-week cooling off period, and not have lawyers sitting there judging about whether these kind of things. And the person who brought up the courts issue, I think it's very right, because when the courts can sort of decide, if you give the courts these kind of decisions, you will have to get lawyers involved in this process. You will have to get lawyers at the deathbed scene. These will be part of the safeguards. Another thing on Oregon, somebody asked about Oregon, and I've just scribbled loads of things down, so if I'm missing something, let me know. But Oregon, why shouldn't Oregon be a successful showcase? Because they are suppressing mission creep. That's the difference between Oregon and other places. They're actually actively suppressing mission creep. They're saying, no, we're not going to extend it to 12 months. We're not going to entertain that because we want all the other states to join us. And until we get 50 states here, we're going to have to remain approximately what we are. And one of the things I'd ask you is that, and this is, I must admit, I teased some of your colleagues about this, Jackie. What are you going to do if the law passes? Are you all going to go home? Or are you going to campaign for the law to go further, as they have in the Netherlands? In the Netherlands, there are 130,000 people who signed a petition to extend the right to end your life to everybody over 70. It didn't pass, but that is what they're attempting to do. Do you think that these activists, have they shut down these societies in the Netherlands and Belgium? No, they're extraordinarily active, and they want to propagate. These are moral entrepreneurs who go in and really are trying to change the culture and allow death as a solution for more and more people. And I think that, we'd be pretending if we just looked at Oregon and said, oh, Oregon's been all right for a little while, we'll try this. I do think also that, and that's the apple fudge and cabbage and whatever else, it's all making me hungry, I know, but at the same time, I think we are talking about very similar things, because basically it's about assisting, and always remember it's assisting a suicide that's the problem in this. This is effectively a state-assisted suicide. That's what's happening. When you get doctors to do this, you're effectively engaging the state with, as you say, 2 doctors and a psychiatrist to assist this particular suicide. I think this is really the sort of basis of the problem. Sorry, what was your question? Because I've gone on.
Well, no, actually, you more or less covered it because
In my
You
own
want to
prose, yes.
Sorry, can I raise a point of information just in relation to the fudging issue of the law? In this country, we have the exact same law in relation to the 1961 Act in Ireland under the 1993 Act. In both cases in which an allegation was made, prosecution was brought in relation to both cases. So this idea...
So who's in prison?
Sorry.
Who languishes in prison for that at this moment? If that's the point.
The person was acquitted in relation to the second. In relation to the second individual, the United States refused to extradite him to stand trial for it. But in both cases, a prosecution was brought in relation to that particular event. So the idea that the law is fudging it in Ireland is not accurate. In the UK, the English DPP, by virtue of a decision of the English House of Lords, required them to issue guidelines, prosecutorial guidelines. They do not exist in Ireland. The other thing is that in relation to the Marie Fleming case, which was brought before the Supreme Court, the big issue for her was not let's keep it quiet and let's do it. It was the risk of prosecution for her husband and her family members. And to talk about
what jury was
to talk about that in a manner which says that that is not an issue for a dying person, that if we keep it quiet and we don't talk about it, that's okay. There's an issue of dignity. There's an issue of someone's going to help me die, and I'm in a terrible position, and I'm really worried about my family members being prosecuted for it. And in all of the cases that were brought in the UK and were raised up to the European Court of Human Rights, that was a consideration of the people concerned. But so this idea that the law is fudging it is inaccurate. It's not true. And the people are still prosecuted in the UK for it. The numbers might be small.
Okay,
and no jury has actually convicted these people. That's the difference here. I mean, we're talking about a law that has worked. Well, nobody has served a prison sentence for this in the UK. I'm not absolutely certain about Ireland. You might be right. But all I would say is that, right now, I think these laws have been in place for how long? I don't know what the Irish...
1993, the law's been.
1993. In the UK, it's been 1961. So we're going back quite a few...
Are convicted of offences. They may not have served time, but they carry a criminal conviction.
But what I'm saying about the privacy aspect is that I don't think in a situation where there are situations whereby it's a grey area and it's not such a bad thing to be a grey area. I don't think people should be prosecuted in those kind of situations. And I don't think that people's relatives should be prosecuted in those situations. Nobody's arguing for that. I'm talking very strictly about a change in the law. And I'm saying that those people, those very few cases where it has come to light for some reason, is one of the approximate 3,000 cases that come up in the UK every year, where it's done very quietly. It'll probably come down because, let's face it, medical technology is getting rid of this, and you have quite a bit of the terminal sedation that seems to be the thing. So that's actually changing it slightly. But I just don't think you can argue that the law hasn't worked very well and it's been, where are these people that are languishing in prison? They're not at the moment.
Okay,
there's no need to change the law.
Ask Jackie to come in on that.
Yeah, and I'm really going to disagree with you. I think the law's not working. One person a fortnight actually has to go over to Switzerland. Those people are really absolutely set on what they want. They can't get it in the UK. Probably between, nobody knows, 300 and 500 suicides a year. One of whom was my brother. He died while trying to commit suicide. He was found at the bottom of a flight of stairs by his wife. Nobody knows how long he was there for. Nobody knows how long it took him to die. The law didn't work for my brother. It's all very well to say there have been no prosecutions, but Debbie Purdy was a big case in the UK. She was a woman who wanted to know that if her husband helped her to die, he wouldn't be prosecuted, and that was where a lot of this got rolling. To be under investigation, it's not about who went to prison, who's been investigated, who's had to go to court, who's had to fight their way through this. That it's not ending up in prison is just one end of the spectrum. So people are afraid. I've just come back from Italy, where a good friend of mine has just died of a very unpleasant death from ovarian cancer. The Italians, of course, will not. This is what happens when society will not take responsibility for what's going on. Had died a very long lingering death. The Italians, of course, won't have anything to do with this. And what they did was leave a box of morphine with syringes and needles in the house with her 21-year-old son and say, you sort it out. So a 21-year-old boy was left administering morphine to his mother, who he was in extreme distress because she was in extreme distress. That's behind closed doors. That's what happens when society doesn't say, we're going to be responsible and take a view on this. That's what happens when they say, we're going to close our eyes because we don't want to know what's going on behind those closed doors. That's a terrible scenario for me. Poor old Oregon, they have suppressed mission creep, but if they hadn't suppressed mission creep, then they'd be criticized for having mission creep. So it seems to me that Oregon couldn't get it right. That they've suppressed the sort of expansion of the law, and that's bad. But if they hadn't suppressed it, that would have been bad as well. I've got all sorts of things scribbled down here. But about the law, the other thing I'd say is you mentioned the DPP, the public prosecution. If we had somebody in the future who decided to come down heavy on this, the law's in place for them to do it. It's only been my new MP is Keir Starmer. I mean, he stood up and argued about this, but somebody else came in who said, I'm going to go after you all. The law is in place for them to do that. And lawyers at deathbeds, I don't think there's any evidence for lawyers at deathbeds. The judicial review was brought in for Falconer as an extra backup, but I don't think the judges are all going to be sitting around bed. And at the moment, the law's not working. It's illegal for doctors to discuss assisted dying with patients. And another survey done recently, because one of the things that BMA has said is, oh, well, it's a big threat to the trust, the doctor-patient relationship. 87% of patients said actually it would either not change or would improve our relationship with our doctor because it would allow us to discuss assisted dying with our doctor, which we can't do at the moment. So the whole business about doctor-patient relationships has been blown out of the water, I'm afraid.
Is there anything you want to come back on that, Captain?
Well, it's not illegal to discuss assisted suicide or assisted dying. Under the 1961 Act, maybe it is, I don't know where else it would be, it's certainly not in that text. I think the key thing is we want doctors to take responsibility. Doctors do so in an estimated 3,000 cases per year in the UK now, and I think that situation is generally working. You're saying that it's not particularly working. I would say that basically the real problem, what I'd leave you with is to say, think of the implications. We're talking about apples, cabbages, etc., but do we really think that you're not going to initiate a situation that's going to end up like Belgium and Holland? If that's what you want, if you want a situation where death is a medical treatment for various different psychological ails, let's face it, many of the deaths in these countries are because of psychological ails, then I think maybe legalization, you could make an argument for legalization. I think, though, that if you're slightly horrified by that idea, where death is prescribed for somebody with tinnitus or for somebody who, there's another case in Belgium, two twins who were going deaf, who were going blind, they were deaf twins already, and they opted for an assisted suicide. Or look at the case in the New Yorker magazine this month. And it's a really interesting case of a guy who favored assisted suicide in the Netherlands, or in Belgium, until he received an email saying that his mother had been killed without any consultation with him. His mother, who had been depressed and under psychiatric care for a number of years, had been killed by the leading doctor in the Netherlands, or in Belgium, Dr. Wim Distelmans. Excellent article. I really urge you to read this and to think about that if you think that legalization is a very good idea. So that's it. This is just concluding.
Just a very small thing.
Very quick, Gabriel.
Okay. The mother was the one who took the decision to die.
That's correct.
The son was not in approval of it, but it wasn't his life, it was the mother's life.
No, but it's effectively a suicide that was accomplished by the state.
But it was her decision to do it.
Yes.
So it was her right to take the decision,
yes,
not the
son.
son.
You want a situation whereby the state is assisting people to die simply because they want, without consulting anybody else, then you're wanting something very different than what I want, which is is a situation where the state is not assisting. If she had committed suicide on her own, nobody would have been able to do anything about it. But she consulted that doctor and asked him to kill her, and he consented. And I think that's wrong.
But if the doctor had asked, they brought the son, and the son had said, no, I don't want my mother to die, but the mother wants to die.
No, the son might have explained that she'd been under psychiatric care and been very depressed in the past. That's why the son was so horrified, is because none of this was consulted. Her own psychiatrist was opposed to the decision. Go, though, to the New Yorker magazine and read it, and then you'll see what you think.
Okay, I think unfortunately we have to finish up.
No.
I know that we've kind of lost some people along the way, which means it's going to skew the final.
They were all my supporters.
Before we finish up, I just want to say that there's so much being touched on and so much to discuss. So let's have a pint. That's really what I want to say.
Agree on that.
Over just in the Palace Bar over there, literally within view of the debate, probably. You know. So we should reformulate, not necessarily reformulate, but refine for the purposes of, by way of closing arguments, what the final poll question might be. And by way of closing arguments, would you care to propose what that might be?
My brain is fried already.
This is apples and cabbages there.
Be specific. Why don't we just stick to the legislation that is on the table?
You're being asked to assist this in dying.
I would put to you, I was asked to do 2 sentences. I would put to you that the law isn't working, that the cases in my own family have shown that, and that my brother's death was particularly brutal, and that if he had known that there was assisted dying, these people have their life stolen from them because they have to commit suicide and they have to travel to Switzerland before their time is up. My brother had to do it because he lost use of his legs through spinal cancer, and he knew that he wouldn't be able to do it. He could have probably lived several months longer if he had known that was available. So I don't think the law's working. And what I'm hearing from my colleague here, and I'm sure we're going to have a pint and make up, is that it's okay to do it behind closed doors, but it's not okay to do it with safeguards in the sight of the law. And I can't accept that as an argument.
Okay, my final thing would be to say that I generally think that we should not be assisting suicides, that the state should not be involved in effectively executing people, even if they have a say-so. So I would say that suicide is the main thing. Do you want a society where suicide is acceptable and that we should all, for instance, applaud at the bottom of the proverbial building when somebody's jumping off and yell jump? I don't think so. So that's what I'm trying to say. If we pass this legislation, and I think the vote for it should be very specifically on the legislation that's proposed in the United Kingdom and in Ireland, very similar based on the Oregon law. But do we want to treble the amount of suicides in the terminally ill, which is exactly what will happen if, according to Dignity and Dying's own figures, the terminally ill, there will be 3 times as many, over 1,000. In fact, you said 2,000. I think it's probably closer to 1,000, but we can argue about that. Or 1,000 people will commit suicide when terminally ill. Right now, 332 people in the UK are committing suicide when terminally ill. So we're going to treble that. I don't think suicide's necessarily a good thing. I don't think it's always a bad thing, but I think in principle we should agree that it's not a good thing. And that's why I would say that it's worth not supporting this legislation and keeping a law that, well, it's not perfect, has worked generally well to stop suicide from becoming more numerous.
Okay, thank you. Can we thank our panel, please, before I go? I just want to make 1 or 2 quick announcements. One, to thank CCT, especially Neil, Carl and Simon, who's been great help with allowing us to use the room and the premises in the first place. Give them a round of applause. We are Dublin Salon, as you probably know, is inspired by the Institute of Ideas, and in October, every October, they have their flagship event called the Battle of Ideas. If you like this, it's basically an orgy of this kind of thing. So it's worth coming over to it. We will hopefully, Dublin Salon will hopefully be producing what's called a satellite session to go along with that. So keep an eye on the website, www.dublinsalon.org.
And there's the Battle of Ideas website.
There's Battle of Ideas.
Battle of Ideas.
But that's London.
17th and 18th of October. Yeah, it is London, yeah. But a short hop away.
Ryanair.
Right, exactly. Poll. 4.
What? 4. Ah.
Legalization. Can you do the headcount representation?
One more time. 9.
All right. Bearing in mind that we've lost a few, but
Yeah.
as you said, they're all your supporters. Hopefully, fingers crossed. Let's see.
Against?
4.
4.
Undecided?
Undecided.
Still undecided?
Yeah, I'm just going to say you've gone from.
I actually think we both made really good points.
Okay, well that's
Food for thought on both sides.
as legitimate as great.
the
Okay.
audience signed up
Yeah. Sorry, how many was it again?
3.
3. Okay.
4, no?
Four.
4.
Yeah. Okay.
Does anybody here, they change their mind?
Yeah, I mean, I suppose I was undecided.
And now you are now?
No, I think definitely legalization, but there's definitely a lot of work to be done on that.
Mm-hmm.
I mean, right, even with 3 options, it's still crude enough because you can go away with having heard more argument than
Lots to think about.
Lots to think about.
I also became more convinced. And the cultural argument doesn't work with me. I think, as I think it was Mary Harney said, we're closer to Washington than we are to Vaughan. I think the American model is something that would fit culturally with us.
Okay. In the best sense of the word, we're moving into the arena of pub talk there. So, very good on that. And thanks everybody for coming.